and hello, everyone. It's really a pleasure to be with you today. Um, so, Greg, maybe I've given this talk before, and I think especially doing this via Zoom with people presumably at home or maybe in their agencies. If you have a question, please don't wait until the end. Type it into the chat box and ask me the question, particularly if it relates to somebody that you're seeing right now, because everything that we know about adult learning theory tells us to the extent you're engaged in a presentation like this, you're more likely to remember more material 10 minutes after I'm done than if you're just listening to me talk at you for an hour. So I don't want to, so Greg, if you would be kind enough to monitor the chat box while I'm talking, and feel free, please, to interrupt me. I'd appreciate that greatly.
Absolutely.
I've been at Psychiatric Institute and Columbia a long time in various clinical and administrative positions. And as the initials after my name indicate, I had a previous career as an attorney. But since that time, for the most part, I consider myself a community psychiatrist. And, and I've been doing trainings for AETC for a long time. So I'm happy to be here with you today. Here is our required disclosure, and here are our objectives. We want to know how often you're going to see personality disorders in the patients you treat with HIV. We want to know something about the various personality disorders in your patients with HIV and what best practices for treatment. In most cases, you're probably not going to be delivering this treatment, but nevertheless, I think it's helpful for you to know what those practices are. This one's important, right? Appreciate how personality disorders can affect the care that you give in terms of engaging with your patients, whether your patients are going to, adhere to what you recommend, and whether they're going to stay in treatment with you. I would say, really, this is the most important objective. Review some approaches to working with your clients who have personality disorders, and understanding conditions to rule out. And I'll say this right now while it's on my mind. In a sense, personality disorders is what you come up with if everything else is ruled out. I would view it almost as a diagnosis of exclusion. And I'm going to just to editorialize for a second. Many individuals with psychiatric and behavioral health care conditions are discriminated against. They'll come into an emergency room with physical complaints and they'll be minimized, and often things will be attributed to a psychiatric disorder. You don't want to make that mistake, and you want to make sure that you've considered other conditions that might account for whatever it is that's causing you to have difficulty with the patient, that's causing the patient to have difficulty with adherence, or causing the patient to have difficulty staying in treatment with you. Having said everything I just said about the objective, I want to say something that's not on a slide, and that is in sort of everyday language, not the kind of language we need to put in these kinds of objectives. In a sense, what personality disorders has become rather stigmatizing in some circles, and I'm going to put it in everyday language. We all engage and deal with people in our lives who we have trouble dealing with, and it can be because whether it's how they interact with us, whether it's how they whether it's their view of the world, whatever it is, we consider them, it's just difficult to engage with them. And those may be people in who you work with. Those may be people in your family. Those may be people whom you have other relationships with. And in many instances, you might have the luxury of just not engaging with them. These are your patients. You have to engage with them. Your job is to treat them. So I think to the extent you're able to figure out what's going on with somebody and have an effective strategy for dealing with them, that's helpful. And that's sort of, I think, putting together all of these objectives. So why is why is this important? Well, it's because many people who you're treating have a personality disorder. You know, my sense is the figure that I think of in the general population, it's somewhere around 10% of individuals have a diagnosis of a personality disorder. And the fact is, if you have one personality disorder, the way that our diagnostic system works, you're likely to have more than that. But look at that figure: 20 to 40% of people with, you know, with HIV are supposedly diagnosed with a personality disorder. And keep in mind, personality disorder, as we'll get into, is really sort of an arbitrary number of traits that somebody has to have to meet the diagnosis. Somebody, and let's say it's 4, somebody can only have 2 or 3, but that person may be much more difficult to engage with and work with than somebody else who has 5. So it's not just the personality disorder. More importantly, it's really the traits associated with that personality disorder. The risk factors overlap, right? So we know now how impairing adverse childhood events can be. And those are risk factors for HIV, but they're also risk factors for many behavioral health care conditions, including personality disorders. Impulsivity, as you'll see, the personality disorders that are really have impulsivity is a prominent feature, are really tied to HIV in a way. So there's a lot of overlap there. And then finally, addictions, right? They travel together: HIV, addictions, personality disorders. And then, like I said before, you need to be able to engage. Hello?
You were good. Someone just entered it, but they weren't on mute, so I got them. Sorry about that.
Okay, thanks. So, I think this seems self-evident to me, right? That in order to be able to work with somebody, the person, you want to have as positive an alliance as possible with the treatment team. And personality disorders or maladaptive personality traits that make up those disorders can get in the way, as I said, of engagement and retention, of adherence. And, that is a problem. And so that's why this is important. So personality, so I'm going to go over this in a little bit more detail, but, it's one of those things, like, I know it when, if somebody asks you to define personality, it's not necessarily that easy. So here according to the DSM-5, personality is sort of made up of traits. They're enduring patterns, and I'm going to go into a little more detail, so I'm not going to spend much time on this, but they're enduring. That's the key word here. And they're seen in many contexts, which makes sense, right? It's how you behave, how you feel, what motivates you, and how you think. And there's been a lot of work on personality traits. It's been a big area of research. I think less so more recently, but there still is. And I actually found a little bit of recent research that I'm going to point out to you at a certain point. But there's been research on how heritable personality is, right? Are you more likely to have personality traits that your parents have? Childhood antecedents, what forms, what are the things that happen to us as children that contribute to our personality? How stable certain traits are over time? Do certain kinds of traits tend to change? And you see that with some personality disorders, the traits associated with those disorders often tend to, for lack of a better word, mellow out with certain personality disorders, where others, that doesn't happen. And then how the functional relevance, how impairing are certain traits. So again, there's been a lot of research. So here's what they say, the Diagnostic and Statistical Manual, the 5th one, I think that was in 2013. This is how that manual defines a personality disorder, right? Enduring pattern, as I said, that it deviates markedly from the expectations of the individual's culture, and that's important. Has to be culturally informed. What might be something that is unusual in one culture and might be maladaptive, might be very much part of another person's culture. So you need to know about that. and it's supposed to be manifest in at least two areas. Not really a functioning, but sort of in two areas relating to the individual. You know, how they think, how they perceive the world, how they feel, you know, their affect, their range of affect, the appropriateness of the affect, how they function with other people, and their ability to, you know, to control their impulses and delay gratification. So it's supposed to be enduring, and it's supposed to be manifested in at least two areas. It's supposed to be inflexible and pervasive, and supposed to and lead to distress or impairment, and is stable and of long duration. So I'm going to say a couple of other things about that. And of course, this is the point I made earlier. You want, this sort of seems almost like an afterthought. It's in almost every, it's in a lot of the diagnoses in the DSM, but you really want to make sure before you attribute, you know, behavior that's maladaptive to a personality disorder, that there's not something else going on, either another psychiatric condition or something else, you know, a physical health condition. So the enduring aspect, again, it's personality. It's supposed to be present, you know, and what age is our personality become stable? You know, I don't think anybody can give you a good answer, but it's not when you're 5 years old, and it's not when you're 50 years old. It's presumably when you're an adolescent or in young adulthood, and it should be stable and chronic. And keep in mind, most of the other disorders, like, you know, major depressive disorder, are sort of psychotic disorders, but affective and psychotic disorders, and even anxiety disorders, are generally more episodic, and that's often a clue as to whether symptoms or signs or symptoms that someone's exhibiting is due to a personality disorder, because it's chronic and stable and you pretty much always see it, although stress and other things can exacerbate certain maladaptive behaviors, or whether it's episodic. Sometimes somebody, you know, isn't displaying any kinds of symptoms, and other times they may be very depressed, very anxious, or psychotic. I mean, this is true for almost all psychiatric disorders. And in our case, with personality disorders, this is usually about impairment. Why? Because there's a slide on this later on. People don't come in to see a therapist or a psychiatrist generally saying, I have a personality disorder, please treat me. Unlike, they may come in and say, I'm really depressed, I need some help. I'm incredibly anxious, I need some help. And then take it from there. The symptoms, personality disorders, it's part of the person's personality. It's so-called ego syntonic. So what's usually going to bring somebody for treatment is that those personality traits that are maladaptive are somehow getting in the way of the person functioning, or getting the person into trouble, or someone else is asking them to get treatment. So for personality disorders, what you're usually going to see is impairment, as opposed to subjective distress from the personality traits themselves. That's not always the case, but it's generally the case. Again, you're going to see this all the time. Rule out another psychiatric disorder, and we'll go over this later, particularly if there's a change later in adulthood. Why? As I said before, it's supposed to be stable from, you know, from adolescence or young adulthood. So clearly, if you see a change in adult, you know, later on, and you may not know the patient, but you may have to ask somebody else, has so-and-so always been like this? That kind of a thing. All right, so let me say one, before I get onto this slide, and I took the slide out, there are other ways of looking at personality. So the DSM actually has an alternative map. You know, the DSM now, it's a categorical model, and you'll see. So for a paranoid personality disorder, you've got to have 4 of a list of, you know, 8 or 9 traits. And that's true for every one of the personality disorders. For avoidant personality disorder, borderline personality disorder, either you have it or you don't. And that seems pretty arbitrary, and also sometimes not that helpful, because if you have even one less trait that meets the criteria, you may not be given a diagnosis, but you really may have just as much trouble interacting and functioning in the world as somebody who does have the personality disorder, because they have an extra trait that you don't meet. So there's a dimensional way of looking at it. And in that model, personality disorders are seen as maladaptive variants of personality traits that we all have that merge into normality. And in that model, personality disorders are looked at as impairments in functioning, self and interpersonally, and then a number of pathological traits that might be present. I told you that there's still research being done, and there's another model out there that I thought was pretty interesting, and they look at personality in terms of scales of introversion and extroversion, and emotional stability versus instability. And introversion and extroversion, very broadly speaking, and there was an interesting point, and it's why I'm bringing it up. They view a lot of people with personality disorders as being way on the end of extroversion, more feeling than thinking, seeking immediate gratification, very much reward seeking, where people who are more on the introverted scale are more logical, able to delay gratification, more cognitively oriented. And the authors of this article made the point that many of us in the healthcare profession tend to be more on the introverted scale, whereas individuals with personality disorders, especially the personality disorders that may be more problematic for those of us, trying to engage with patients and take care of them, and really for you. There may be a disconnect there. So it may be difficult to understand, why can't this person delay, this person's killing themselves. I don't understand why they don't want to, why can't they at least think about getting treatment for their, alcoholism? So I think that's just an interesting point there, that, you sometimes have to put yourselves in the shoes of the other person. You're not going to do this. You're not going to do a semi-structured interview, right? That's not what you're doing. This is what, people in behavioral health care clinics will do. And even there, they don't do much of that. The problem with the diagnosis here is that, it can take a long time. You have to get to know people. So usually, and I think from your point of view, you can take a look at this slide, but I think to the extent you're able to engage a family member or a significant support with your patient's consent, that may give you a little bit, and without alienating the patient, to ask questions about whether or not what you're seeing is the way somebody has always been. That may be a way of getting at whether or not something is a personality disorder. But again, I don't think being for your purposes, you don't have to diagnose a personality disorder. What you want to know, I think more importantly, what you want to know is what you're seeing is what's getting in the way of you providing the treatment you want to provide due to that person's personality, whether or not they technically have a personality disorder within the meaning of the DSM. So, personality disorders among people with HIV and AIDS. We know from the National Comorbidity Study, which is a landmark study in psychiatry, a landmark epidemiologic study, which is old but still cited, that substance use disorders are highly comorbid with other psychiatric disorders. It includes borderline personality disorder, as well, and I'll say as well as antisocial personality disorder, which are the two personality disorders we'll spend a little bit more time on today. As I said before, they're very common among people living with HIV. This was a study by a group who looked at men who were incarcerated in North Carolina with borderline personality disorder. And not that surprisingly, and a lot of this has to do with the impulsivity, borderline personality disorder was associated with multiple sex partners, drug use with sex partners, having sex with all high-risk behaviors. I looked this group up, and in fact, it looks like they did a similar study a couple of years later with antisocial personality disorder and had similar results. Again, not surprising. The bottom line being that individuals with borderline personality disorder and antisocial personality disorder are more likely than people who don't have those disorders to engage in impulsive risk-taking behavior, which is obviously associated with HIV. So this is a bunch of data basically telling you that these things, that substance use disorders, antisocial personality disorder, borderline personality disorder, are grouped together. They co-vary. So here you've got almost about half of individuals with a substance use disorder also meet the criteria for antisocial personality disorder in one study. And look at this, about 90% of people with antisocial personality disorder also have a co-occurring substance use disorder. And then, sorry about that, I'm not so good with this. 50% of individuals with a lifetime diagnosis of borderline personality disorder, again, substance use disorder. People with substance use disorders are more likely than not to have a personality disorder. I mean, they're all basically saying the same thing. The substance use disorders are prevalent in individuals with borderline and antisocial personality disorders, and those individuals often also have substance use disorders. Injection drug users more likely to have personality disorders. In this study, about 20% had antisocial personality disorder or borderline personality disorder. And again, when I give you these percentages, remember, for the most part, these are people who meet the diagnoses. You're going to have many more people who will have traits that very well may be very impairing. And as I've said a couple of times before, individuals who don't meet the diagnosis, but who have significant traits of some of these personality disorders, may have more trouble engaging with you than individuals who actually meet the full criteria. So you've got to sort of, to the extent you see percentages, I would consider them significantly higher when you take into account the fact that there are many people who are sub-threshold for the diagnoses. Let's see. All right. The clusters. The way the DSM handles this is they take the 10 personality disorders and put them into different clusters. The odd and eccentric, we're going to go over them briefly, and then spend a little bit more time on two of the disorders. Important point, and one of the reasons many people think the whole way we deal in psychiatry with the personality disorders, this diagnostic system isn't necessarily that helpful. There's tremendous comorbidity, meaning that somebody who has one personality disorder often has many. And then the other problem is that the most common diagnosis is an unspecified personality disorder, one that doesn't necessarily meet the criteria for any particular personality disorder, but where an individual has a number of traits that are spread out among different personality disorders, and those traits are causing them impairment more likely, or subjective distress possibly, so they have a disorder. But just, the take-home point here is that there's a lot of comorbidity. So, so you'll see in the next one, there's a leftover. Before I get to my bit of humor, paranoid personality disorder is just what it says, right? A pattern of pervasive distrust and suspiciousness of others, such as motives are interpreted as malevolent. So these are people who, it can be difficult to perform a relationship with. These are people who may be guarded, who may be secretive, who may not trust you fully. They're not psychotic. You remember, this doesn't go to the point of where someone's psychotic, but it's a way of it perceiving the world. The world is a dangerous place to people who have paranoid personality disorders, and they react accordingly. And frankly, in my experience, it's different as a psychiatrist. Someone's not going to come in and tell me I have paranoid personality disorder, but they're not going to, their chief complaint isn't going to be, I'm too paranoid. When they come to see you, they're coming to see you presumably because they want help with their, in this instance, because, they have HIV and they want you to help them, but they still may be suspicious of you, and you've got to take that into account. So there was a time, and now no, and I can't see you, so I don't know if you're gonna know this, but it's gonna really date me. I tried to take movie characters for some of these, so you'd to sort of bring the personality disorder to life, so to speak. So bear with me. And I can't tell because I can't see you, and I have no way of knowing. The quintessential personality disorder was from Mutiny on the Bounty with Humphrey Bogart, Captain Queeg. He wasn't psychotic, but he was incredibly distrustful, right? And interpreted and very referential, and interpreted his crew was trying to mutiny. And he's a good, if you know that movie, you got a good image in your mind of somebody with paranoid personality disorder. Now, schizoid personality disorder, this is somebody who is like the quintessential loner. And the important thing here is that these are people who aren't looking to have intimacy. They don't want to have intimacy. And there are people who may not respond to social cues. They may seem odd. They can engage with you, but you're not going to get a lot back from them. But these aren't people who are going to generally act out in a way that's detrimental to them, but you may have some difficulty engaging with them, although they can show up. Now, schizotypal is similar in that schizotypal, and this is a disorder that is seen to be, is probably related to schizophrenia. First degree relatives with schizotypal disorder are more likely to have schizophrenia. Here you also see people who are loners, who don't interact well with others, but they also have sort of odd, or what we would call eccentric behavior. It's important in this instance to make sure that cultural reasons why some may seem that way. Again, these are people that you can engage with, and in most instances, I think that you're going to be able to engage with them and get them the treatment they need, unless they become psychotic, and it can become more challenging. All right, I'm going to say a little bit more about antisocial personality disorder. I'll, give you a movie character, although he's also a psychopath, which I'll go into. Hannibal Lecter, right? Silence of the Lambs. Everybody knows about Hannibal Lecter, but I'm not going to say much right now because I'm going to talk a little bit more about antisocial personality in a bit. The same with borderline personality disorder. I didn't delete those movie characters, right? That Alex Forrest, and that dates me, right? Fatal Attraction, the Glenn Close character, and Silver Linings Playbook. Jennifer Lawrence, was Tiffany Maxwell. Those are individuals in movies who were deemed to have, who were sort of supposed to have borderline personality disorder. Then you've got histrionic personality disorder. I'm going to give you another movie character, Scarlett O'Hara from Gone with the Wind, right? These are people who will engage with you. They'll come in. They may be very flattering. They're people who are attention seeking oftentimes. But again, they may be overly familiar with you, calling you by your first name. And I'm completely generalizing here. But again, I view this as one of the personality disorders or cluster of personality traits that shouldn't really generally get in the way of you providing treatment. Unlike narcissistic personality disorder, where people can be sometimes difficult to engage with, people can be very sensitive, they can be entitled, they can cause problems. So this could be an individual who might treat someone better based on their status, feel that they need the best doctor or whatever, the discipline is. People who are grandiose, they can devalue other people. So somebody who's very narcissistic, and I'm sure you encounter people like that in your lives outside of your work, can be difficult to deal with, difficult to engage with, and can arouse a lot of feelings in you, which can get in the way of you doing what you need, providing the treatment that you want to provide, or engaging how you want to engage. So this is one of the cluster of personality traits that can make it difficult for you to engage how you want to engage with an individual, or for that person to engage and stay in treatment with you. And then finally, we have the anxious and fearful clusters. I mean, the first two don't tend to, avoidant. I mean, there are people, this is seen on a spectrum with social anxiety disorder, people who want to have, unlike schizoid or schizotypal individuals with those personality traits, people with avoidant personality disorder generally want to have relationships with other people, but are very rejection sensitive, are afraid of embarrassing themselves. Now, I guess in the vernacular, you would say, well, if they're avoidant, they may avoid treatment, but they're not. If they're avoiding engaging with you in treatment, it's generally not they're being avoidant per se of wanting to help themselves. The avoidance comes from the generally would come from the personal interactions between them on the one hand and you and your treatment team on the other. That's what the avoidance is. It isn't so much an avoidance of, it's not an avoidance of receiving help. It's an avoidance of the personal interaction and being inhibited and being, fearful of embarrassing oneself, that kinds of things I've mentioned. Then you've got dependent personality disorder. Those people will engage with you, but they make you feel responsible for them. And so they'll come to your office, I think, as often as you want them to come to your office, and may almost be overly, excessively, quote, compliant. And I use that word on purpose. But they can also, generate feelings in you of like feeling the need that you need to take care of them in a way that doesn't feel right, or that makes you uncomfortable. And then finally, obsessive compulsive personality disorder. Those are people who are very perfectionistic, orderly, inflexible, and it's not to be confused with obsessive compulsive disorder. That's a different entity. That's people who have compulsions and obsessions, and that could be a very impairing behavioral health condition. This is a personality disorder, considered a personality disorder. And this is a person who will come in, want as much information as possible generally, maybe try to sort of exert control over their treatment, when they feel out of control, that's when people with this cluster of traits can have difficulty. So again, this personality disorder is one where people with these traits can have difficulty engaging with you and you with them. So let's say a little bit, I'm just checking time. All right, I'm going to have to speed up a little bit. Let's say a little bit about antisocial personality disorder. So this is what it says, and not complying with social norms, being deceitful. Here's the one: being impulsive, right? People who get into fights, who don't have enough regard for their safety or others, consistent irresponsibility. There's a lack of remorse, right? You just don't genuinely feel bad if they've hurt somebody or done something to somebody. Supposed to have had a conduct disorder. Again, it's not your job to make a diagnosis of antisocial personality disorder. So this is, when you want collateral history, that's really for the mental health care professionals. There's the idea, there are a lot of people who work in this area who think that the DSM focuses too much on behaviors rather than the character traits. And so if you go into a forensic setting, into a correctional institution forever, 90% of the individuals will have antisocial personality disorder. And they feel that psychopathy is a more useful concept, which focuses more on the emotional characteristics, the lack of empathy, the charm. Hannibal Lecter, it's not always superficial. And, that's just something to keep in mind. So this is important, I think, how you might feel if you're treating somebody who you think is antisocial. Therapeutic nihilism. Nothing I do is going to matter. It doesn't help. Forget about it. That can happen. Feeling you have an alliance where you don't. Think Hannibal Lecter again. Not that you're going to be treating Hannibal Lecter, but the way he interacted with people. you may, it may be that you may be being manipulated, and it may be that the person isn't doing what they're saying they're doing, and the alliance you believe you have is illusory. You may feel in danger, and it could be warranted. Somebody could get, usually people with antisocial personality disorder, the kind of violence that's perpetrated is purposeful for a reason. So the chance, I think, of being assaulted due to this is low, but there are times when if in your gut you feel fearful, there's probably a good reason. The opposite is true. Again, this isn't going to come up as much in your work. It comes up more in our work and individuals who work in correctional settings, that the opposite can happen. There can be there might be a dangerous situation, not just to you, but to a third person, and a person might underestimate the risk. This can bring about, you can feel helpless, you can feel guilty. I can't help this person. I mean, this relates to the first thing, to the therapeutic nihilism. The way you feel when you're unable to help somebody, they're not engaging, you're feeling responsible for them, and you just feel helpless because there's nothing you can do, and you may feel guilty because this person may be getting sicker right in front of you while they're in your care. And then finally, and this is true, just as an important concept, that because I'm not sure how much I'm going to get through, hatred and rage, and countertransference just means how you feel. Think of it that way. You may be really angry at somebody. And I'm just going to say, as a general matter, in case I don't get to say it later on, a take-home point is, if you have a client or a patient that you're interacting with who's generating strong feelings on your part, you need to take a step back and think about why that's happening, and probably speak to some of your colleagues and see if they're having similar reactions, because something is going on, obviously, in the interaction, and there very well may be, a personality disorder, and the personality traits can be one of those things that could generate strong feelings. And it's not just antisocial personality disorder. It can be narcissistic traits. It can be traits associated with borderline personality disorder. Generally, I would say those three, and that if you're really getting very strong negative feelings, but if you're getting strong feelings, you want to take a step back. That's the bottom line here, and figure out what's going on, because there's a good chance it can get in your way. So the other personality disorder that makes sense to spend a couple of minutes on is borderline personality disorder. So let me step back a second. Antisocial personality disorder is, over the years, traditionally more diagnosed in men. It may be present more in men, but there also may be a bias there. Conversely, borderline personality disorder is associated more with women. There may be a bias there as well. There's a lot of stigma associated with this disorder. You should be aware of that. These are people who are desperate, who in the, at least according to the DSM, are desperate not to be abandoned. And that would include by you, who have very unstable tumultuous interpersonal relationships, trying to fill a void. They don't have a good sense of self. And here's the part that relates to the risk factors for HIV: impulsivity, right? That hurts themselves. And so you've got it right there: sex and substance abuse. These are people who can engage in self-mutilating behavior. They're at an elevated risk of suicide. Because somebody's self-mutilating doesn't mean that they're can't also be, have suicidal behaviors or kill themselves. There's a lot of comorbidity. Again, I'm not going to spend too much more time on this because I want to get through the other slides. But they're very reactive. And these are people who, you may have trouble, you or your people you work with, you may have trouble treating. I mean, this is a personality disorder that can get in the way of treatment. I've really talked about this before, right? This is something, this can be, you're going to have to, you don't have to worry about the diagnosis, I don't think. I think, and as I said, people aren't going to come in and say, please help me, I have a paranoid personality disorder. What's going to happen is, for your purposes, you're going to have trouble, in some part of the treatment relationship. And that's when you're going to take a step back and try to figure out what's going on. And if other things don't appear to be relevant, you're going to think, well, maybe this person has maladaptive personality traits. They may have a personality disorder. What do I do next? Here are some rule outs, because these are the things that can look like personality disorders, right? The HIV dementia, a psychotic disorder. Now, people can be psychotic and be paranoid and also have one of these personality disorders. But again, when someone's psychotic, they're psychotic and have a fixed, false, delusional belief, which is generally not the case with the personality disorders. It's because somebody's abusing substances and maybe even, engaging in antisocial behavior to feed that addiction. That doesn't mean they have antisocial personality disorder. Certain mood disorders can look like borderline or narcissistic personality disorder. The anxiety disorders can look like some of the other personality disorders. PTSD, I'm going to say something because I just want to, let me say, autistic spectrum disorder, people with schizoid or schizotypal personality disorder, because of the way they don't engage, can sometimes look like people with, a mild autistic spectrum disorder, or even a learning or communication, issue. So you want to be aware of that. But again, those are people you'll generally be able, I think, to engage with. I'm going to put PTSD off for a second. So I'm going to spend, I think you know more about this than I do. The take-home point here is subcortical dementias, you are more likely to see the personality changes than with dementias like Alzheimer's disease, which are cortical dementias. But again, the clue here is that somebody's personality has changed. If it's changed, it's likely not a personality disorder. Same thing here, some CNS infections as well. So here are some things I wanted you to look at, that you want to, if you see these things, you just want to be aware they may be associated with a personality disorder. Suicidality, cutting, which I told you is associated with self-harm and borderline personality. Lying, especially if somebody doesn't, is very glib about it. Again, you may not be in a situation where somebody is actually lying to you, but that is something associated with antisocial personality disorder. Yeah, be careful if somebody tells you the best, because the next day you may be the worst. You may be the best, but be careful when somebody tells you that. That's called like who idealizes you, because you then may be devalued. That's again a trait associated with borderline personality disorder. Excessive promiscuity, I told you about a lack of remorse associated with anti-personality disorder. I told you about self-centeredness associated with narcissistic personality disorder. And again, this isn't an academic exercise. This is if these things are getting in the way of your treatment relationship. Your job isn't to treat these maladaptive behaviors. Your job is to deliver care for an individual's HIV, and it's only if these traits are getting in the way that I think that they're really your concern. And this is the last one here, strong emotional reactions. That's the countertransference, and that's probably the most important one, because that will, because a lot of the others, if they're happening, will probably, a lot of the other items here and others will generate a strong emotional reaction. So that may be sort of the most sensitive way of figuring out if there's something going on in the relationship that's attributable to a personality disorder or something else. You find yourself having a much stronger reaction to your patient than you normally do. So this is what I wanted to say. So, the opposite of sort of somebody has a mental illness and they have a chemical imbalance, this is another way of looking at it, that there's a lot more that goes into it, right? I just feel, and with what's going on in the world, we need to point this out. and that physical and mental health is, and I'm sure this isn't new to you, is also driven by other factors. And here you go. And I'm not going to read them all to you, but presumably these these things and people's backgrounds and what people are, the way people are living, has an effect on their physical health and has an effect on their mental health, and food insecurity and poor access to health care and housing instability, all other things equal, that's not going to help a person's mental health. And that's true, I think, also for how personality disorders manifest themselves. I think that's for sure, if not personality itself. And then there's a concept of trauma-informed care, which I'm sure you've heard about. And that's really being sensitive to what people have been through. And I'm saying trauma in the broadest sense. And that can be trauma due to incidents, you know, what's in the news, what we're all protesting about now, trauma due to police brutality. It can be chronic trauma due to racism. It could be intergenerational trauma. I think not, again, in your roles, I don't think this is something that you're going to dwell on and interact with your patients, but I still think it should inform how you view and view and interact with people. I don't think it's going to be the subject matter of what you talk about. But I just wanted to get these in there, and that's why I deferred PTSD. Let's see, we've got 5 minutes. So maybe, let's see, let me go through this. So you want to communicate effectively, you want to listen to people, you want to be consistent, you don't want to be totally responsible for somebody, say, with dependent personality disorder, and you need to have some hope. And so therapeutic nihilism is to be avoided. Working as a team to the extent you can is extremely important. You've got to speak to each other. You want to try to everybody to be on the same page. Another take-home point is if you see there's a lot of strong feelings about a patient and different ideas about what's the best way to treat a person, you want to take a step back and figure out what's causing that. And in my experience, that doesn't usually happen. And it can happen because there are genuine differences of opinion. It can also happen because the person is interacting with people in a way that generates that kind of splitting. So you want to use shared decision-making when you can, set certain kinds of limits when you need to, focus on long-term goals, speak with each other and communicate, and if you can, integrate primary and mental health care. So I'm not going to go into the therapies, I think, because you're not going to be doing them. Just know that there are therapies out there for individuals with personality disorders. Medications don't help that much for the most part, but there are a number of treatments, and if somebody needs a referral, that's what and it's because you can't handle it on your own, you're unable to engage, that's probably when you want to make a referral. So, somebody with significant maladaptive personality traits can be challenging, especially if they're in the antisocial or borderline spectrum, and there's substance abuse present. Cohesive team treatment, right? Speaking with each other, getting supervision if you need it, consult with people. That's very important. Managing your own feelings is essential. Obviously, you want to focus on dangerous behaviors, and there are times when people need to be hospitalized. So I think that's it. I believe I have 2 minutes.
Thank you. So I was monitoring the chat. I didn't see any questions come through, but if you do have one, you can throw it in the chat now, or feel free to unmute yourself as well. And thank you for the presentation. And thank you to everyone for sticking with us through our tech issues. Well, and while we're waiting to see if any questions come in, just a reminder, everybody, we'll send an evaluation email out. Please fill that out. The sooner that you fill that out, the less emails you'll get about it, I promise. We did get a question here. Eva said, is it common to have more than one personality disorder at a time?
Yes, it's very common, and it's one of the criticisms. It's one of the can you hear me?
Yep.
Yeah, no, somebody asked, is it common to have more than one at a time? It's very common, and it's in fact one of the criticisms of the whole diagnostic system of personality disorders, that you get so many that it's not necessarily that helpful. But yes, it's very common. What is the most important thing to do if you think your patient has a personality disorder? I think the most important thing to do is to try to figure out as best you can what it is that's getting in the way, to put it in, to speak with your colleagues and figure out what's getting in the way. How is it hurting the patient? How is it interfering with your treatment relationship? Seeing if you can go about ameliorating that, and if you can't, if there's a way to refer a person, if they're willing, to behavioral health treatment, even, or speak to someone for a consultation. Even if the patient isn't willing to go, maybe you've got somebody who could help you, where you can run what's going on past somebody, and you can ask for some help. How do we handle this person, insists on controlling their own treatment and won't listen to our recommendations at all. Shared decision making to them means they decide without any input from us. What can we do? I'm making that up, obviously. But I think the most important thing is to figure out what it is that's getting in the way of providing effective treatment.
Perfect. Well, thank you. And thank you, everybody. Have a good day. If you have any other questions, feel free to let us know. All right. Thanks.
You're welcome.